Uh, so let's go to the next second part of today's meet. Well, this is a didactic talk, and the topic is something pretty interesting: erectile dysfunction. And the speaker is well known to all of us, Dr. Mathew. He's a consultant at Welcare Hospital, and the session will be chaired by Dr. Deepu George, who's a consultant in medicine at the Medical Trust Hospital. Dr. Deepu is well known to each one of us. He has been very active in all academic sessions. His inputs have been very valuable in extending the academic discussions in our API column. And we all would like to listen to Dr. Deepu and Dr. Bobby. Dr. Deepu, kindly please take over the chair.
Thank you, Radhakrishnan sir. Am I audible enough?
Yeah, you're very much audible. Thank you.
Okay. Thank you. And it is almost like coming back home. I've been missing in action from API for quite some time, and not because of any excuse or anything else. Been a little held up with department activities at the hospital, and it's been a little hectic like all of you have. But I hope to be here more often than doing right now. But I guess my job for the day is quite simple because Bobby doesn't need a great deal of introduction to anybody in this API group. But the customary basics of introducing the speaker has to be done. So I'll go through the CV in short. Bobby did his MD General Medicine from Toronto Medical College and did his DM in endocrine from KEM. And he has specialized in areas of andrology, diabetes mellitus, thyroid, obesity, growth hormone deficiency, and PCOS. But on a personal note, Bobby started his career, if I believe correctly, from Medical Trust Hospital as a consultant endocrinologist with my present organization. He presently stays at Kuchkodandra, and he's among the few endocrinologists who manages to crisscross across the seas and practice in Kochi, Changanasheri, and if I'm not mistaken, Sharjah right now. So he's going to give us a talk from across the seas, and I really look forward to listening to Bobby, because as I call Bobby's talks, he's probably the fastest speaker among anybody I've heard in my life. So we have nicknamed him as Kerala Express, and rest assured of a lot of interesting practical tips from Bobby. And it is a topic which begs to be given more attention than what we usually do in our academics, in our clinics, and in our own interaction with our patients. So I would be very interested in knowing how Bobby approaches this topic from a clinician's perspective, because as a trainer for my postgraduates, I always insist that they read up these topics in detail, because if it comes and then you haven't gone through it at a theoretical level, it is almost impossible to fudge. And it is heartening to see API take an initiative to actually give a lot of importance to this oft-reported problem, which is not being adequately addressed in our clinicians' practice. Erectile dysfunction as such is something that we literally shy away from asking our patients, and most of our patients are also a little hesitant in conservative mode to come forward and discuss with us. But I'm sure Bobby will have his own ways in which he tackles these issues. He will definitely give us pearls of wisdom about how he tackles it, how we confront the patient, how we comfort the patient, and how we go about with the treatment algorithm. Over to you, Bobby, and I hope that we can mute the other mics till Bobby finishes the talk. I know how irritated he gets with interruptions in between, so please mute the mics, all of you, and I'm sure we can take the questions at the end of the talk, because sir is giving a talk from abroad. Please do wait for him to finish, and we have almost 1 hour of absolute bliss awaiting us, and we will have a good interaction at the end of the talk. Over to you, Bobby. Thank you. I guess I'll get going with a few discussion points straight away, so that once Bobby joins, I'm sure I can stop in between anytime, just to keep the audience engaged. Okay.
Yeah, thank you.
Yeah, so when somebody discusses the topic of erectile dysfunction, it is basically, even if you go by the basic textbook or the Bible, for most of us as physicians, it's still basic science from Harrison's, and most of the times it is basically an approach which requires us to see what the patient is coming to us with. At what stage of erectile dysfunction is he talking about? Does he have a lot of comorbidities which need to be addressed? Does he have a lot of underlying diabetic problems? Does he have atherosclerotic problem? Does he have cardiological problems? What is his neurological status? And that approach also involves a lot of detailed history. What is he trying to describe with this erectile dysfunction? Does he have a problem with initiation? Does he have a problem with staying erect? And does he have a problem with ejaculation as such? So these are history which are very, very important in our approach to the patient. And it also involves a detailed look at what the present medications of the patient are. Depending on what the history has been given to us, then we approach what kind of an erectile dysfunction this particular patient is trying to tell us. So I'm sure Bobby, with his vast experience of endocrine, will be trying to tell us about where we need to investigate, what are the type of investigations that you should be ordering, which patient would benefit from medications, what kind of drug modification should we be doing, what kind of tightening of control do we expect from the present medications, like if his diabetes is under control or not. Does he have a neuropathy which is creating a problem? Does he have a problem with the filling phase where there is an atherosclerotic issue? Does he have an arterial problem? And what are the approaches in which we will approach this on a treatment perspective? So these are the things that I look forward to Bobby to answer. I'm sure there is enough and more theoretical stuff on the Harrison's platform and on various Mayo Clinic and other esteemed sites where it is given in simpler language. But from a physician perspective, I would definitely be interested in listening to Bobby and telling us how he approaches a particular patient and how, on a practical sense, each of us can take home message of how to approach this problem, how do we initiate the talk, how do we expect the patient to give us further details, and what are the kind of medications that we should be careful in the prescription of the patient that probably the patient is already getting us, and what kind of modifications we can do from our own side. And a lot of focus has started happening, especially in Kochi. I'm sure there's a lot of andrology clinics and all coming up in a big way. How much of it is justified? How much of testosterone assays do we need? How much of patients require testosterone injections? And a lot of people are actually exploited for this simple an issue, because I'm sure there's a lot of counseling or a psychological support also which is needed. Okay. And I'm sure once Bobby joins us, he will be enlightening us on this not so easy a problem to approach, and let's see if we can have a good discussion at the end of Bobby's talk as such.
Yeah. Hi, everyone. This is a talk on erectile dysfunction, not classical erectile dysfunction per se, from physician's point of view. We are in the physician's club meeting. So actually, physician's point of view, how to approach an erectile dysfunction person. And ED, many times we know what's the definition of ED. Harrison has explained ED as the definition. It's an inability to attain and or to maintain an erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. That is, don't look at the slides, just concentrate on me. So ED is defined as an inability to attain and or to maintain an erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. That is, if a person is not able to attain erection, that is erectile dysfunction. If a person is able to attain erection but not able to maintain that erection, that is also erectile dysfunction. If a person is able to attain erection, maintain the erection, but not of the sufficient rigidity that he wants for a sexual intercourse, that is also erectile dysfunction. If a person is able to attain an erection, maintain an erection, that too of the sufficient rigidity that he wants for the sexual intercourse, but he or his partner doesn't get a satisfaction out of the sexual act, then also the purpose of erection has failed. So that is erectile dysfunction. So ED never means a total lack of erection. ED is one among the pathway of erectile dysfunction. It can be an inability to attain erection, maintain erection, and to get a sufficient rigidity or to get a sufficient time so that your partner enjoys an orgasm. A failure to attain any of this is known as ED. When we all used to study for MBBS, MD, during my Harrison period also, MD period, 16th edition of Harrison, second chapter, that is 16th edition and second volume, first chapter or second chapter, it is known as impotency. So when we all used to study for MBBS MD, the term ED was not at all existing, or SD, sexual dysfunction, are not at all existing. The term was known as impotency. Now, by the revised NIH guidelines 1992, the term impotency itself is taken down from all the textbooks. That is why you never address a male now as an impotent guy. You know, it's a Malayalam shunned and impotent, never. So the modified term of ED or SD, that is sexual dysfunction, because addressing a male as an impotent guy is thought to be a great insult to manhood per se. Just like the disorders of sexual differentiation. Previously, it was true hermaphrodite, female hermaphrodite, male hermaphrodite. Now, nothing. These are all disorders of sexual development. So, it's a modified term or a more dignified term. And what is the cause of ED? Massachusetts male aging study have shown that. In the picture. So, Massachusetts male aging study have shown that only 10% of men less than the age of 45 years have organic ED. That means that 10 people coming to the OPD less than the age of 45 years with erectile dysfunction. 1 out of 10 only have an organic ED. 9 out of 10 is having a psychogenic ED. So as your age increases, the organic ED percentage increases. 50% of the men above the age of 60 years and 80% of men above the age of 80 years have some sort of organic ED. This Massachusetts male aging study is very, very important, because in the US also we know erectile dysfunction and to an extent infertility is not at all covered by insurance. So less than the age of 45 is any guy coming and telling you umpteen number of history of ED, you think that 90% is psychogenic, 10% is organic. Suppose a married guy at the age of 75 years or 65 years comes and tells you, doctor, I'm married for the past 35 years. I was enjoying a good sexual relation with the wife, but for the past 3 or 4 years, I'm not able to perform an adequate sexual act. That means that it is not a psychogenic ED, it's an organic ED. That never means that a person of age 80 years is not able to have a sexual intercourse with a sexual partner. A person of age 80 years may be having tumescence sufficient enough to have a penetration with his partner. He may not be enjoying that rigidity which he used to enjoy before the age of 45 years. So basically from this slide, I'm going for 10 or 12 slides. I'll be finishing 30 minutes. Basically understand there is no longer existing a term known as impotency. It is ED or SD per se. Less than the age of 45 years, 10% only have organic ED, whereas more than the age of 50 or 60 years, 50 to 80% who come to the OPD with complaints of erectile dysfunction are having organic ED. Psychogenic becomes less as your age increases. Goes to the next slide, Sandeep. Fine. Next slide. Yeah, what are the stages of the male sexual function? I don't know how many doctors are there. I see only Deepu or Prasanna Kumar sir, per se, or Radhakrishnan sir. But basically understand, because usually I get charged by seeing the faces. But basically understand, there are 4 stages of male sexual function. I've taken everything from Harrison only. Stage 1 is the stage of libido or desire to have sex. The moment you think of a female that you want to have sex with, the moment you hear the sound of a female you want to have sex with, the moment you see a pornoclip, you have a libido kicking in your brain. So second is the stage of erection. Once you have a libido or your drive to have sex, the penile blood flow increases, blood fills into your penis or the corpora, and the corpora bulges, and that's the process of erection. So first is the stage of libido or desire to have sex. Once you have libido, your penis bulging occurs and you have a tight erection because of the blood filling into the corpora. Third is the stage of actual purpose of having an erection. That is either an intercourse or a masturbation and ejaculation. So first is the stage of libido. That is you are thinking you want to have sex with, or you are touching your penis, you are having a libido. Second is the blood pumping into the penis, you are having an erection. And third is the purpose of having an erection, either a masturbation or an intercourse and having an ejaculation. Fourth is the stage of detuminescence. Don't think that every person after an ejaculation will have a detuminescence. No. If your sympathetic activity overtakes your parasympathetic activity, then your erect penis will come down. If your sympathetic activity is not able to overcome the parasympathetic activity or drive of acetylcholine, you can have multiple orgasms with an erect penis with ejaculation occurring multiple times per se. And what is the stage of libido? So understand each this. I'll be just touching and finishing what Harrison have told. Libido in a male is controlled by 2 factors, testosterone and mental state of mind. However high your testosterone is, if you are in a depressed state of mind, however high your testosterone is, you are going to a female, she is abusing you, you are talking to her, her smell is not at all good, a pungent smelling mouth, that itself kills the sex. So libido is controlled by testosterone as well as mental state of mind. And the penile blood flow, always understand what is the process of erection. Go to the next slide, then I will explain to you. So before going to the cause of erectile dysfunction, think of penis. Think of what we have studied in Ganong and Guyton. We have all studied Ganong and Guyton rather than Harrison in the first MB. So penis is a soft tissue organ, just like our finger, which gets converted to a rigid rod-like organ, which is capable of penetrating any intact vagina during the process of erection. So penis is just a soft tissue organ. So penis is made up of two groups of vascular smooth muscle, a central midline corpora spongiosa, which bulges anteriorly to form the glans penis, and a pair of corpora cavernosa on either side. So basically understand, we know the cross section of penis, a central midline corpora spongiosa, which bulges anteriorly and form the glans penis or the bulb of the penis. On either side, there's a pair of corpora cavernosa. Corpora cavernosa are the actual organs of erection. So what are the types of erection? Whatever 5 or 10 doctors hearing understand, there are two types of erection I have told you: neurogenic erection and reflexogenic erection. What is neurogenic erection? Once you are in your teens up to the age of 50 years, the moment you think of a lady, the moment you hear the sound of the lady, you have a tight erection of your penis without even touching your penis. That is your thought alone. Your parasympathetic nerve fibers in the posterior hypothalamus is activated. From there, impulses are coming down to the S2, 3, 4 segments of the spinal cord. From there, where the nervy agent is to the parasympathetic nerve fibers of the corporal cavernous endothelium. So you are just sitting in your movie theater, or you are just sitting talking to your girlfriend without even touching your penis. You are having a tight erection of your penis. That is known as neurogenic erection. But as your age increases above 45 to 50 years, your strongest desire to have an intercourse with a lady or sex with a lady may not cause a 100% erection of your penis. It may cause a tumescence of your penis. You may require touching or caressing of your penis to have an erection. That is known as a reflexogenic erection. First is thought causing an erection. Second is touch causing an erection. So you know the peripheral nerve supply of the penis, the sensory nerve supply of the penis is by S2, 3, 4 nerve root, that is by the pudendal nerve. So understand, once you have a neurogenic erection, good, at the age of 45 or 50. Suppose a guy at the age of 55 is coming to the OPD here, because you know almost 20 days I work in UAE here and 10 days there, but majority of the so-called business people and all, I deal mainly with andrology, pediatric endocrinology. Suppose a guy comes and tells me, doctor, my age is 55 years, doctor, I'm diabetic, but my libido is so good, doctor. When I see a good lady, I have a good erection, I don't even need to touch my penis. That means that in spite of having sugar, BP, cholesterol, in spite of undergoing angioplasty, his penile endothelium, corporal cavernous endothelium is so good that the moment he thinks of a lady, his penile endothelium is firing nitric oxide, he is able to have a tight erection. That means that his coronary endothelium is also, and his carotid and femoral endothelium, everything is probably working normally. So neurogenic erection at any moment shows that your penile endothelium is very good. Suppose this guy is coming and seeing me at the age of 58 years and telling, Dr. Bobby, when I saw you 2 years back, my erection was so good, doctor. I used to think of a lady, I had a good erection. Now I can't think of a lady, I have an erection. I have to touch and caress my penis to have an erection. That means that his reflexogenic erection or whatever reflexogen is activating, but his thought causing a nitric oxide firing from the endothelium is coming down. So basically understand, that's why I tell you, imagine the corpora cavernosa, corpora spongiosa. So what is the mechanism of erection? You know, I have told you, a central midline corpora spongiosa, a pair of corpora cavernosa on either side. What is corpora? Corpora is vascular smooth muscles. So what is vascular smooth muscles? We know it is smooth muscles with endothelial lining. So it's just like your blood vessel. So you imagine your penis and corpora is a cross section. It is just having endothelial lining. Whenever you have libido, the endothelium is producing nitric oxide. Nitric oxide is causing vasodilatation, and blood pumps into the corpora cavernosa from the internal pudendal artery, which is a branch of internal iliac artery. So actually, erectile dysfunction is no longer ED, or ED is no longer erectile dysfunction. Now the name for erectile dysfunction is endothelial dysfunction. That is, a person after having adequate libido in the absence of stress with normal testosterone is not able to produce an adequate penile erection. That shows that his corporal cavernous endothelium is not able to produce adequate nitric oxide for penile vasodilatation. The same can occur in his coronary artery also. So imagine the erection. So that is why ED is not at the level of brain many times. It is not at the level of spinal cord. It is at the level of the corporal cavernous endothelium that erection has to occur. So that is why ED, the biggest risk factor is no longer diabetes. It is always endothelial dysfunction, diabetes, hypertension, hyperlipidemia. Now understand whatever I have told you in concise. Erectile dysfunction is the inability to attain and or to maintain erection of sufficient rigidity and duration so as you as well as your partner get an adequate sexual satisfaction. Less than 10% of men less than the age of 45 years only have organic ED. Above the age of 50 years, 5 out of 10 people come to the OPD and doesn't have a psychogenic ED, they have an organic ED. First, to have a sex, your libido should be good. Second, to have sex, your blood should pump into the corpora. The central midline corpora spongiosa contributes to only 20% of erection. The pair of corpora cavernosa, the bulky vascular smooth muscle of corpora cavernosa, which actually produces erection. So how does erection occur? When you have libido, your brain, you are getting the glimpse of a lady you want to have sex with. What happens? Your corporal cavernous endothelium, just like any other artery endothelium, femoral artery, coronary, carotid artery, it produces nitric oxide. Nitric oxide causes vasodilatation, and the blood has to pump into the corpora, and the corpora goes into erection with blood filling into the corpora. And understand, the corpora is covered by a thick connective tissue sheath that is known as tunica albuginea. Beneath the tunica albuginea runs the dorsal vein of the penis. So once your corpora bulges, it causes compression on the dorsal vein of the penis. So it's a watertight mechanism. The blood coming into the corpora is not able to go out of the dorsal vein of the penis, and you're able to maintain erection till you have an ejaculation with a sympathetic activity. Sympathetic activity causes cavernous artery vasospasm. So invariably, the blood flows out of the corpora, but you're able to control your sympathetic activity by routine practice. That is why people who have a frequent sexual intercourse can have multiple orgasms up to the time. Many of the people report an adequate rigid penis with a good endothelial activity can have 100% erection in a continuous period up to 1 hour and 30 minutes. After 1 hour and 30 minutes, just like doing a push-up, you are doing 50 push-ups. After that, lactic acid accumulates in your muscles. You have a muscle hypoxia. You have to take a rest for 30 minutes so that your muscle gets regenerated. You have to hydrate yourself, take salt and water, and then again do push-up. So after the period of maximum 90 minutes, your penile endothelium gets exhausted. So after that, you require some amount of rest to the penile endothelium for nitric oxide regeneration to occur. So this is the basis of erection. So understand, ED is no longer impotency. ED is no longer erectile dysfunction. ED is now endothelial dysfunction. So understand the next sentence which I have told always: a person after having adequate libido in the absence of stress with normal testosterone. So you are having adequate libido, you are having no stress at all, you are relaxing at your home, your testosterone level is more than 3.5 nanogram per ml, but your girlfriend is there, you are having a libido, your penile erection is good, no stress at all, you are in a room with AC sitting, but still you are not able to produce a penile erection. That shows that your corporal cavernous endothelium is not producing nitric oxide. The same can occur to the coronary artery also. That is now the role of 65. That is 65% of the people with an organic ED have an underlying coronary artery disease. Vice versa, 65% of the people who have already suffered from an organic coronary artery disease have a history of ED. If you take a history of ED 5 to 10 years prior to the onset of a heart attack per se. So now go to the Endocrinologist of North America or Harrison data. What is the biggest risk factor for ED? When we used to study for MBBS, MD, I finished my MBBS Government Medical College Trivandrum, 93, 99, MD also Trivandrum Medical College 2000, 2003. That time you opened Harrison Davidson. The biggest risk factor of ED was thought to be diabetes per se. Now we know sugar never kills your sex. So many papers now published in the diabetes care have shown that type 1 diabetes children who develop diabetes at the age of 10 or 12 years, you follow up them at the age of 70, 80 years, their penile function is totally intact, 90% their coronary is intact, whereas type 2 diabetes, the earliest percentage itself can be an underlying coronary artery disease or an underlying penile dysfunction. That is, you are having a child with type 1 diabetes at the age of 13 years, admit with the diabetic ketoacidosis, you are following up the child becoming an adult at the age of 70, 80 years. At the age of 80 years also, his BMI will be 21. He may be having an HbA1c of 10. He may be having very bad retinopathy, neuropathy, nephropathy, but the penile endothelium will be totally intact. That shows that your HbA1c never kills your sex. It is not the sugar that is going to kill your sex. Now, the biggest risk factor for erectile dysfunction is abdominal obesity or metabolic syndrome with or without diabetes. So that is why all the guidelines say that abdominal obesity or metabolic syndrome. So how does metabolic syndrome kill the penile function? Metabolic syndrome associated hypertension, hyperlipidemia, insulin resistance can cause endothelial dysfunction by decreasing the nitric oxide production. Whenever you're abdominally obese, you have insulin resistance, your total testosterone, free testosterone comes down. That can also contribute to ED. And third sentence, understand, when we all used to study for MBBS, MD, we used to study that thyroid gland is the largest endocrine gland in the body. Now we know this adipose tissue that is now considered to be the largest endocrine gland in the body. So as our abdominal adipocytes get more and more bulkier, it produces free radicals which can directly kill the corporal cavernous endothelium. So the cake in the 90% Malayalis, doctors on the cake in the room, facing, but basically understand the concept with my energy, I tell you. So ED is endothelial dysfunction. Think of your corpora, just think of your blood vessel. It has an endothelium. It has to produce nitric oxide for penile vasodilatation and the blood to pump into your corpora or your penile endothelium and to fill and have a good erection by touching the tunica albuginea. But once you have a sugar, BP, cholesterol, that is destroying the corporal cavernous endothelium. Once you are a smoker, that destroys the corporal cavernous endothelium. Once you are having hypertension, that also destroys the corporal cavernous endothelium. So the biggest risk factor for ED is no longer sugar. It is metabolic syndrome or abdominal obesity. Second is smoking. Third is hypertension. And the rule of 65, age more than 45 years, 65% of the people who come to the OPD and tell doctor, my sexual performance is coming down for the past 5 years. You know that they may be having sugar, BP, cholesterol, obesity, smoking, that is causing endothelial dysfunction. So 65% of the situation you do a triple vessel angiography, they may be having a single to triple vessel coronary artery disease. So that is why you say that when your HbA1c, go to the next slide. Deepu, you are hearing? Anyone is hearing?
Yes, Bobby, please proceed.
Okay. So this is the most important slide. This is why these urologists are slowly shifting away from treatment of erectile dysfunction. Erectile dysfunction is now in the hand of physicians. Actually, all the GPs, all the physicians, all the cardiologists, endocrinologists has to do erectile dysfunction. Treatment of ED is just with phosphodiesterase inhibitor, sildenafil, tadalafil, vadinafil. Treatment of ED is with intracavernosal alprostadil injection. You have now Pfizer's Coverjet injection. Treatment of ED is with penile processes. That is done by urologists. But you and me, every physician, every endocrinologist, every GP, every cardiologist, we only can prevent erectile dysfunction. Look at the diameter of these vessels. Each gram of HbA1c above 6.5, each millimeter of mercury above 130 by 80, each milligram of LDL cholesterol above 70, each puff of cigarette you smoke, each snore you snore because of obesity is first occluding the narrowest artery in the body. Malayalathil parnal, each gram of HbA1c above 6.5, each millimeter of mercury above 130, each milligram of LDL cholesterol above 70, each puff of cigarette that we smoke, each snore you snore with hypoxia due to obstructive sleep apnea will occlude the narrowest artery in the body. That's the concept of ED and coronary arteries is shown in this slide. It is just like a water tank in a home which is not at all used. Malayalathil parnal, ഞാൻ ഒരു വീട് വെക്കുന്നു, ഒരു 6 മാസം മുമ്പ് അതിനകത്ത് വെള്ളം അടിച്ച് ടാങ്കിനകത്ത് ഇട്ടു. ആ ടാങ്ക് ഞാൻ എടുക്കുന്നില്ല, വീട് ഉപയോഗിക്കുന്നില്ല. 6 മാസം കഴിഞ്ഞ് ഞാൻ വന്ന് പൈപ്പ് തുറന്നു. പൈപ്പ് തുറക്കുമ്പോൾ എനിക്കറിയാം ഏറ്റവും വലിയ പൈപ്പിൽ നിന്ന് നല്ലതായിട്ട് വെള്ളം വരും. ഏറ്റവും കൊച്ചു പൈപ്പിൽ തുരുമ്പും പായലും എല്ലാം കൂടെ കയറി അടിഞ്ഞിരിക്കും. ഞാൻ തുറക്കുമ്പോൾ നമുക്കറിയാം വെള്ളം ചീരി ചീരി ചൂ ചൂ എന്ന് പറഞ്ഞ് വന്നുകൊണ്ടിരിക്കും. നമ്മളൊരു കമ്പി എടുത്തിട്ട് അത് 2 കുത്തു കുത്തുമ്പോൾ വെള്ളം നല്ല ഫോഴ്സ് വരും. That is the same concept of erectile dysfunction. The narrowest blood vessel in the body is your cavernous artery. Look at the diameter with all the Harrison and Gas endocrinologists of North America has given. The diameter of your cavernous artery is 1 to 2 millimeter. The diameter of your coronary artery is 3 to 4 millimeter. The diameter of the carotid artery is 5 to 7 millimeter. And diameter of a femoral artery is 7 to 8 millimeter. So the narrowest artery in the body is the cavernous artery, which supplies the corporal cavernous endothelium. The more wider artery is the coronary and carotid artery and femoral. So you can put a catheter or a stent in the coronary, carotid as well as femoral artery catheterization. But you can't put a catheter in your cavernous artery, which is 2 millimeter. So whenever your HbA1c is high, whenever your BP is high, whenever your LDL is high, whenever you are smoking, whenever your obesity, it is first occluding your corporal cavernous endothelium, then only your other blood vessel. That is why ED is now in the hand of endo. ED is now in the heart of cardiologists. ED is now in the heart of GPs who treat patients from the age of 18 years. Suppose my age is 45 years. Suppose I need to keep my penile endothelium intact, just like the way I am having it now till the age of 50 or 60. What should I do? Each gram of metformin which I take to keep my HbA1c less than 6.5, each millimeter of mercury which I reduce by taking a losartan, telmisartan, olmesartan, each milligram of LDL cholesterol which I keep less than 70 by taking a rosuvastatin per se, each puff of cigarette that I throw away, each step of exercise which I do is actually protecting my 3 endothelium. It is first my corporal cavernous endothelium, then my coronary, then my carotid, then my femoral artery endothelium. So basically, rather than treatment of ED, it is prevention of erectile dysfunction that is important. Whenever you control your metabolic syndrome profile, you are treating your ED or you are preventing an erectile dysfunction from occurring. Once your endothelium is destroyed, നമ്മൾ പറയുന്ന ഒരു വ്യക്തി പറയുന്ന ഡോക്ടർ 25 വയസ്സിലെ ഷുഗർ സ്മോക്കിംഗ് നല്ല വലിയ ഡോക്ടറെ ഇപ്പൊ 40 വയസ്സായപ്പോൾ ബ്ലോക്ക് വന്ന ഡോക്ടറെ 3 സ്റ്റെന്റ് ഇട്ടിരിക്കുക എന്ന് പറഞ്ഞാൽ നമുക്കറിയാം അവന് 25 വയസ്സ് ഷുഗർ ഉണ്ട്, അതിൻ്റെ കൂടെ BP ഉണ്ട്, കൊളസ്ട്രോൾ ഉണ്ട്, കൊറോണറി ഓൾറെഡി ബ്ലോക്ക് ആയി, കൊറോണറിക്ക് 4 millimeter ഉണ്ട്. അതിനു മുമ്പേ അവന്റെ കവർണോസ് ആർട്ടറി എൻഡോത്തിലിയം ബ്ലോക്ക് ആയി. സോ എൻഡോത്തിലിയം ഉണ്ട്, പക്ഷെ നൈട്രിക് ഓക്സൈഡ് ഉണ്ടാവുന്നില്ല. തൊട്ടും തലോടിയും എത്ര സ്റ്റിമുലേറ്റ് ചെയ്താലും, പ്രുഡന്റൽ നെർവ് സ്റ്റിമുലേറ്റ് ചെയ്താലും നൈട്രിക് ഓക്സൈഡ് ഒരു 20% വരും. ആ നൈട്രിക് ഓക്സൈഡിനെ ഓഗ്മെന്റ് ചെയ്യാൻ വേണ്ടി കുറച്ച് സിഡനാഫിൽ ടെഡലാഫിൽ എടുക്കാം. പക്ഷേ ഒരു 2 years കഴിഞ്ഞാൽ പിന്നെ നൈട്രിക് ഓക്സൈഡ് പ്രൊഡക്ഷനേ ഇല്ല. Still HbA1c is killing the endothelium. Still BP is going to kill. Still he has not quit smoking, and he will attribute everything to the antidepressive tablet he is taking. He will attribute everything to the statin he is taking. He will attribute everything to the modern medicine he is taking. But actually, his metabolic syndrome and smoking has killed his penis. So understand this much. This is the basis of sex. So go to the previous slide once more. Sandeep, tuttu mumbelthe slide. So this is the basic of sex. Wherever you go forward, and the brain and the friend, but ED is this thing. So erectile dysfunction occurs as a function. No, next, yeah. So ED is always endothelial dysfunction. The biggest risk factor of ED is not sugar. A type 1 diabetic child having sugar at 30 or 40 years, HbA1c alone will not kill the endothelium. He should have a BP, he should have a cholesterol, he should have obesity. But type 2 diabetes itself is metabolic syndrome. It will kill the sex. Second is smoking. Third is always hypertension. So erectile dysfunction, 65% of the people with organic ED have an underlying coronary heart disease. So understand the basic dictum. Each gram of HbA1c above 6.5 controlled by metformin. Each millimeter of mercury above 130 controlled by a sartan. Each milligram of LDL cholesterol above 70 controlled by a statin. Whenever you smoke, throw it out. Always exercise and keep your BMI less than 25 or 27 is possible. So ultimately your endothelium is clear. Your 2 millimeter corpora cavernosa is firing like anything, and that is able to prevent an erectile dysfunction per se. And why was I telling hypertension and sartan? So some people come and ask, doctor, I'm having erectile dysfunction. My doctor cardiologist gave me Concor or Nebi. Is it causing ED? Does antihypertensive stuff cause ED? Now studies have shown that erectile dysfunction is contributed by antihypertensive drug in only 5% of people. It is actually hypertension and underlying endothelial dysfunction which kills the sex. But vice versa, a person having organic ED, which is the safest antihypertensive drug, that is nothing but ACE and ARB is the safest, and the worst is always diuretic, especially aldosterone antagonism. Second safest. Losartan, Telma, Olma, or patient potassium higher with ED. He can't take a Losartan, Telmisartan, which is a second safest drug for ED. It is always alpha blocker. Your Prasopress, Dynapress, Prasopress group can be given, or invariably, what's the side effect of an alpha blocker? It can cause retrograde ejaculation. Native patient, he's coming and telling me, doctor, my wife is just 25 years. I'm just 54 years. I underwent a robotic prostate surgery. He went to some other country, France, even he went a robotic prostate surgery. But my sex is good, doctor, but my orgasm, my semen is not coming. So what happened? That is known as retrograde ejaculation. Everything. This is a physician's point of view. I'm not seeing the face, but basically we are physicians. But a guy comes and says, doctor, my orgasm is good, but nothing is coming out, doctor. So what is happening in my body? I don't know. So think that what are the causes of retrograde ejaculation? It can be diabetes, it can be spinal cord damage, it can be transurethral resection of prostate, it can be tricyclic antidepressants, it can be alpha blocker. So tamsulosin with the patient is taking with the history of TERP, he is done. It is retrograde ejaculation. How do you confirm that? You ask the patient to masturbate or have a sexual intercourse. You have an orgasm. You know it is a retrograde. The semen is going into the bladder. Postcoital urine sample. Ask the patient to collect a postcoital urine sample, centrifuge it, and show him it is full of spermatozoa. And what's the treatment? Suppose a person undergoes a TERP and comes and tells you, doctor, I'm a retrograde ejaculation. My orgasm is good, but I want to see semen. So what should you do? You can give an alpha-1 agonist as midodrine. You know, midodrine alpha-1 agonist 5 and 10 milligram, which is now accepted as the first-line treatment for orthostatic hypotension. Or at times you can give a sympathetic agent, sympathomimetic ephedrine. Ephedrine also 30 milligram, 3 to 4 tablets can increase the sympathetic tone, and it can increase the spasm of the prostatic, whatever sphincter is there, and it can prevent a retrograde ejaculation. These are the tips. So from this, we will go to the treatment, the testosterone, and finish in 10 more minutes. Go to the next slide. So basically 1 more minute stop. This is the basic dictum. You understand the narrowest diameter is cavernous artery. And what are the laboratory evaluation do in a guy with ED? Now you know erectile dysfunction divided into 2. Think and look at me once more. Psychogenic, organic. Psychogenic, more common, less than 45 years. Age more than 45 years or 50, many people will not commit psychogenic. They have organic thing. But actually, how do you differentiate between a psychogenic and organic? Always ask the history of duration of ED. Suppose a guy comes and tells me, Dr. Bobby, I went to my wife almost 2 weeks back. So invariably, I had an intercourse. First, it was a very good intercourse, doctor. But 2 weeks after I'm just coming back today for yesterday, I tried to have an intercourse with that. My penile erection is not good. And he's telling that, doctor, yesterday I slept and got up in the morning, my erection is very good. That means that a pure psychogenic ED. He had a good sex 2 weeks before 2 days before, when he was leaving, he had anxiety with his wife. He didn't have a sex. Yesterday he came, slept here, and morning he's having a tight erection. That knows that in between he's having an erection, in between not an erection. That itself is a history of psychogenic ED. Number second, a guy is coming and telling, doctor, I masturbate so much. I see so much porn movies. I masturbate. When I masturbate, my erection is so good, doctor. I have a 100% erection. I go to my wife, doctor, I don't feel any libido at all. My erection is just 60%. That means that you are living in an imaginary world. You are getting so much kick and imagination when you see the movie. When you see your poor wife who is living with you for 15 years, you are not having a kick. You are thinking of all these movies and having a kick of 60%. That is also psychogenic ED. Suppose a guy comes and tells you, no, Dr. Bobby, my sex is very good up to 5 years back. Over 5 years, my erection power is coming down, doctor. I am able to attain erection, but not able to maintain erection. I am able to maintain erection, but not of sufficient rigidity, doctor. I tried masturbation, not good. My morning erections are so poor, doctor. I tried seeing movies, still my erection is not good. For the past 5 years, I have never seen a 100% erection of my penis. That shows that it's a pure, organic, slowly evolving erection. Whereas a guy tells that, doctor, yesterday I had sex, today my sex is low. It's a pure psychogenic ED. In an organic ED guy, about 45 years, what are the routine tests to do? The first and foremost, test 5 basic dictum from Endocrinologist of North America, Urology Clinics of North America, and our Bible, that is Harrison, that is taken. Invariably, FSH, LH, testoprolactin. Second is T3, T4, TSH. Number 3 is lipid profile. Number 4 is LFT, RFT. Number 5 is HbA1c. And number 6 is PSA if age is above 40 years. So basically understand the male hormone of testosterone, the thyroid, the lipids, the LFT, RFT, the HbA1c, and the PSA. And what is the importance of doing hormone profile in a man? I always tell you, men miserably miss their hormone because females have a wonderful thing that's known as a menstrual cycle. Because suppose my wife is 39 or 40 years, suppose she misses her menses for 3 months, or she gets an irregular periods once in 50 days or 55 days. She will tolerate it for 3 months. After that, what will she do? She will go to a gynec. Gynec will do an ultrasound abdomen to look for a polycystic ovary. If that is negative, gynec will ask for an FSH, prolactin, TSH to look for a premature menopause, hyperprolactinemia, or a hypothyroidism. Whatever, she will pick up a hypothyroidism or a polycystic ovary, premature menopause, or a hyperprolactinemia. So a female knows that their menstrual cycle days are missing, they will go and get evaluated. Suppose a guy at the age of 45, suppose I am 44, 45, 46, suppose another of my elderly colleague 48 years, is having some sort of erectile dysfunction. What will he attribute to? He will attribute to the stress he is having, he's attribute to the smoking, alcohol he's having, the sugar, BP, cholesterol he's having, probably the tablet for sugar, BP, cholesterol is taking, probably the lack of interest in the wife, probably till that the wife uterus has been removed or the children are grown up, so I don't enjoy sex, I had enough of sex in the past. He will never ever go and take his testosterone, prolactin, or even TSS. That is why we always say any guy with organic ED invariably has to check the testosterone, invariably has to check the thyroid. Because thyroid disorder, we know, complicates 10% of females and 1% of men. 1 in 10 females, 1 in 100 men have hypothyroidism. But how many of you and me have checked the TSH for the past 6 months or 1 year? Because females do check the thyroid function for everything. Weight loss, weight gain, alopecia, myxedema, or constipation, diarrhea, menorrhagia, amenorrhea, you name it, you go to any doctor, they always ask for TSH in a lady. But how frequently does a guy check the TSH? How frequently does a guy check the testosterone? This is the basic. That's why I told you, my slides I put as 10 or 15. It's from my eyes, my visual communication that I do. But this is the basic. Whenever sex, because this is the subject, andrology, pituitary, erection, endothelium. This is the subject which I see maximum. I took endocrinology for pure andrology and testosterone. No other hormone, thyroid, parathyroid, everything is there, but pure testosterone. So basically, I've told you, it is ED. The cause of ED is nothing but endothelial dysfunction. You have to control it by HbA1c, BP, cholesterol, avoidance of smoking, and exercise. But once you develop an ED, rather than keeping everything, you do the basic test and do the testosterone assay. Go to the next slide. We'll be finishing in 10 more minutes, Deepu, don't worry. Next slide. Yeah. So this is the concept of andropause. We know that females have a menopause. What is the definition of menopause? Permanent cessation of menstrual cycle due to the exhaustion of the ovarian follicles, which is diagnosed retrogradely 1 year after the last menstrual cycle. Okay, Harrison definition is permanent cessation of menstrual cycle. How does a female know about menopause? Doctor, 1 year I am not having menses. Extreme hot flushes, doctor, especially night time, hot time, stressful. Okay, you are going to a gynecologist. Gynecologist asks for an FSH. FSH more than 40. You know it's undergoing. She has undergone a menopause, or you're doing an AMH. AMH is less than 0.2 nanogram per ml. You know it's a menopause. But how does men know that testosterone? Men never know their andropause or decreasing testosterone with time, because even though your testosterone is 0, suppose you are doing a bilateral orchidectomy for a CA prostate also, your residual testosterone levels are there in the hair follicles. 10% of testosterone is still coming from your adrenal cortex. So your mustache will be growing daily. Maybe the frequency of your beard growth, you're maybe shaving daily. Maybe you're going to shave once in 3 days, but you will never know because you don't develop a late onset gynecomastia. Maybe your sarcolemmal mass will come down. Maybe you have a slight amount of dementia or an anemia or a cognitive dysfunction or a mild amount of lipomass. You will never know. So in very now the concept is that testosterone comes down in men about the 40 years. The concept of andropause or male menopause or penopause or viropause. Now the name is LOH, late onset hypogonadism. Under Adam, androgen deficiency in aging males. Pay the textbook, it is known as LOH or late onset hypogonadism. Previously, it was male menopause. Now the term is not diagnosed because male menopause is a misnomer because the testosterone comes down, but the fertility never comes down. A person of age 75 years may be having a poor erection, but he can give the semen for an artificial insemination or an IVF because the testosterone comes down, the fertility never comes down. So, so how to check the testosterone? Now, entering the testosterone story. Suppose any doctor hearing this at the age of 55 saying that my libido is good, but my erection is not good. I'm not able to keep a good penile erection. My rigidity is not good. Or someone is saying that I'm having a premature ejaculation. I need to check my testosterone. So what is the time that you are going to check your testosterone? Or suppose you have a patient with ED, you need to check your testosterone. So first ask the patient to take testosterone in the early morning before 11 o'clock. Previously it was 10. Now European male aging study before 11 o'clock in the morning. Patient total testosterone check here. So total testosterone more than 3.5 nanogram per ml is normal. So you are checking a total testosterone first. 3.5 nanogram per ml above, it is normal. Less than 3.5 nanogram, okay, consider it is a late onset hypogonadism. Leaking, going little more details. In IMA, detail the pure physicians. You have heard Harris and every clinics of North America. So I'm going little more clear. I don't know how many people are listening. So normal total testosterone less more than 3.5, don't bother. Otherwise, testosterone level less than 2 nanogram per ml is diagnostic of hypogonadism. More than 3.5 seconds, 2 to 3.5 nanogram per ml is a borderline zone. So whenever you treat if it's less than 2.2 nanogram per ml, more than 3.5 you don't treat. 2 to 3.5 nanogram per look for the 3 cardinal symptoms of male hypogonadism: decreased libido, erectile dysfunction, decreased frequency of morning erection. So whenever you find it less than 2, treat. More than 3.5, never treat. 2 to 3.5 ED, decreased libido, decreased frequency of morning erection, treat the patient. But before that, we have to confirm what is the cause of hypogonadism. So at the value testosterone less than 3.4, treat the under. All the guidelines say that wait for 3 weeks. After 3 weeks, ask the patient to do a FSH, LH, testoprolactin in the morning before 11 o'clock. Testosterone low with FSH, LH high, it's a primary testicular failure. Testosterone low with FSH normal or low normal or low, it's a secondary hypogonadism or a late onset hypogonadism. You may do an MRI pituitary if you suspect a cellular mass or an empty cellular syndrome. Otherwise, it's a late onset hypogonadism. But understand, poorly controlled diabetes, poorly controlled patients with metabolic bone disease, metabolic gastrointestinal disease, mainly ulcerative colitis, Crohn's disease, COPD, long-term steroid therapy, everything can mimic a secondary hypogonadism. So normal walkie-talkie testosterone no 2.5 testosterone 2.5 with FSH, LH, prolactin low or low normal. I think it is a secondary hypogonadism. Do for an MRI if you suspect a cellular mass only. Otherwise, consider it as a late onset hypogonadism and start treatment with testosterone. Go for the next slide. Sandeep, go for the next slide. Yeah. So what about testosterone? Each zone are important. But Deepu, you don't have to refer many of the cases to an endocrinologist. Endocrinologist, what is endocrinologist? At some specialty, okay, pituitary. Suppose you have a Cushing syndrome. Suppose you have a hyperparathyroidism. Very bad osteoporotic bone with a T-score more than 3.5, where you have to get teriparatide, or a precocious puberty, or a growth hormone deficiency. There, endocrine is very important. At times, a type 1 diabetes. Back testosterone replacement, thyroxine replacement, hyperthyroidism. Basic guidelines over a version revise. But testosterone എടുക്കാൻ ഒരു യൂറോളജിസ്റ്റ് കൊടുത്ത് അയാൾ വായിക്കുന്നതിനും കൊണ്ട് ഫിസിഷ്യൻ നന്നായിട്ട് വായിച്ച് ഡേവിഡ്സൺ ഹാരിസൺ വായിച്ച് വെച്ചിട്ടുണ്ട്. ശരി, നമുക്ക് കൺഫ്യൂഷൻ, ഈ ഡോസ് കൊടുക്കാമോ, സൈഡ് എഫക്ട് വരുമോ? യു നോ ദാറ്റ് ഈവൻ ഇൻ എ premature menopause is menopause occurring before the age of 40 years. Normal average age of menopause Indian is thought to be 50.3 years. So you know that suppose a lady has a total abdominal hysterectomy at the age of 40 years with no contraindication for menopausal hormone therapy, she should be given a Premarin or a Tibilon till the age of 51 years. എന്നാൽ പോലും നമ്മുടെ നാട്ടിൽ 45 years ഒരാൾക്ക് നല്ലൊരു ഗൈനക്കോളജിസ്റ്റ് ഒരു ടിബിലോണോ പ്രമാനോ കൊടുത്താൽ ഇമ്മീഡിയറ്റ്ലി ബാക്കി ഡോക്ടേഴ്സ് പറയും ഹോർമോൺ ഒക്കെ കഴിക്കണം, ബ്രസ്റ്റ് ക്യാൻസർ വരത്തില്ലേ, കഴിക്കേണ്ട ആവശ്യമുണ്ട്. There you are putting the hint that it can cause a breast cancer. Breast cancer is synonymous with post-menopausal long-term HRT beyond 60 years. This is a premature menopause. 51 വയസ്സിൽ നിൽക്കേണ്ട മെൻസസ് എൻഡോമെട്രിയോസ് കൊണ്ടോ ഇൻഫെക്ഷൻ കൊണ്ടോ യൂട്രസ് ഓവറി എടുത്ത് മാറ്റി അവർക്ക് 51 വയസ്സൊരു ഈസ്ട്രജൻ വേണം, അത് നമുക്ക് കൊടുത്തിരിക്കണം. Otherwise it causes more mortality because of low HDL and increase in small dense LDL per se. But this concept that all the hormone replacement therapy is side effect, people in that thyroxine no side effect, type 1 diabetes insulin no side effect, where എന്ത് കൊടുത്താലും ഗ്രോത്ത് ഹോർമോൺ എടുക്കേണ്ട ആവശ്യമുണ്ടോ, പിള്ളേർക്ക് ബാസ്കറ്റ്ബോൾ കളിച്ചാൽ പോലെ, കമ്പി വിളിച്ച് തന്നാൽ പോലെ, സെക്സ് ഹോർമോൺ ഇല്ല, ടെസ്റ്റോസ്റ്ററോൺ ഒക്കെ എടുക്കണം, അപ്പുറത്ത് പോയില്ല ആയുർവേദ ഗുളിക കഴിച്ചാൽ പോലെ, മുസ്ലിപ്പോർ കഴിച്ചാൽ പോലെ, അല്ലെ ഈസ്ട്രജനോ, പെണ്ണുങ്ങൾക്ക് ഈസ്ട്രജൻ എന്താ, കൊച്ചുങ്ങളൊക്കെ ഉണ്ടായില്ലേ, പിള്ളേർക്കൊക്കെ 10-15 വയസ്സായി, ഇനി എന്തിനാ ഹോർമോൺ എടുത്ത് ക്യാൻസർ ഒക്കെ വരുത്തുന്നത്? സോ ആ കൺസെപ്റ്റ് ആണ് ഒരു ആൻഡ്രോളജിസ്റ്റോ ഒരു എൻഡോക്രോളജിസ്റ്റോ യൂറോളജിസ്റ്റോ ടെസ്റ്റോസ്റ്ററോൺ എഴുതിയാലും ചിലപ്പോൾ അറിഞ്ഞുകൂടാത്ത ഹോർമോൺ ഒന്നും എടുക്കേണ്ട, പ്രോസ്റ്റേറ്റ് ക്യാൻസർ. സോ ദ കൺസെപ്റ്റ് is inbuilt in our brain that testosterone therapy causes prostatic cancer. Never. There are two types of testosterone treatment. Understand the basic term. Testosterone replacement therapy, that is TRT, and testosterone supplementation therapy. Testosterone replacement therapy is replacing testosterone in a person whose testis is not producing testosterone. So ഒരാൾക്ക് hypogonadism ഉണ്ട്, testis ഉണ്ടാക്കുന്നില്ല, അല്ലെ pituitary testicular axis ഉണ്ടാക്കുന്നില്ല, so you replace. Another guy 25 years ജിമ്മിൽ പോയിട്ട് പറയുന്നു എനിക്ക് മിന്നൽ മുന്നേ പോലെ 6 pack വേണം ഡോക്ടർ ബോബി, എനിക്ക് 6 pack വെക്കുന്നില്ല, അടുത്ത ഷൂട്ടിംഗ് എനിക്ക് 6 മാസം കഴിഞ്ഞ് തുടങ്ങും, കുറച്ച് 6 pack വെക്കാൻ മരുന്ന്. There I am giving a supplementation, I am not giving a replacement. Now studies have shown that testosterone replacement therapy in hypogonadal men never induces prostatic cancer. It only uncovers the microscopic foci of prostatic carcinoma. And TRT can almost be safely given till the age of 65 years. And menopausal hormone therapy can almost be safely given till the age of 60 years. So ഒറ്റ വാക്ക്, നാളെ ഇത് കാണുന്ന ഏതെങ്കിലും ഡോക്ടർ അവരുടെ തന്നെ ടെസ്റ്റോസ്റ്ററോൺ ചെക്ക് ചെയ്തു 2.5 നാനോഗ്രാം 3 ആഴ്ച ചെയ്യുമ്പോൾ FSH, LH, ടെസ്റ്റോപ്രൊലാക്റ്റിൻ വിത്ത് ടെസ്റ്റോസ്റ്ററോൺ, everything is low. He knows that it's a late onset hypogonadism. You want to start yourself on testosterone replacement therapy. What will you do before starting? You do a PSA and PCV. Basal PSA more than 4 nanogram per ml, basal PCV more than 52%. Don't start. Go to a urologist, go for a prostatic biopsy. Suppose you are starting, PSA is less than 4, PCV is less than 52%. You are repeating PSA, PCV 3 monthly, 6 monthly, annually, and the rise in PSA is more than 1.5 nanogram. That shows that it's an uncovering of microscopic foci of prostatic carcinoma induced by the replacement therapy. There you go to a urologist and go for a prostatic biopsy. Otherwise, when your PSA is less than 4, your rise in PSA is less than 1.5 nanogram, you don't have to bother at all. TRT is totally safe. And what is the form of testosterone replacement you will give? Will you give an injection? MBBS days, we know the injection of testosterone enanthate sustained, that is known as sustanon 250 milligram once in 3 weeks. Now we have long-acting testosterone ester, testosterone undecanoate, that is given 1000 milligram once in 3 months. That is known as Serenos Depot or Tehim Depot. So if a patient on the sustanon ella masum venda, Serenos Depot, Tehim Depot, or UAE international brand is Nebido. That's the international brand. So 1000 milligram once in 3 months. But in person with ED, you don't require an injection. You require pure oral testosterone. So testosterone undecanate capsule is there. That is known as Andreol Testocap or Serenos Testocap, 40 milligram 3 times daily. Ask the patient to take for 3 months, come back with a total testosterone PSA. So roughly, now your patient testosterone correlating ED, decrease libido, decrease bone mass, lipomastia, or increase gynecomastia per se, cognitive function, dementia, whatever it is, the patient is coming, you are doing testosterone. My father is age of 76 years. Actually, he was a retired police officer, conferred IPS. So he was put on, he is already on metformin 1 gram body, HbA1c 5.8. He's on statin invariably, LDL cholesterol I keep it always less than 70. He's on losartan potassium, BP is normal. So vitamin D is taking vitamin E. But at one point of time, PSA was normal. Severe fatigueness, he is a policeman, so much exercise he used to do, but severe decrease in sarcolemmal mass and tiredness and fatigueness and some amount of dementia. We know that, okay, somatopause, your growth hormone can come down, but it can be a question of testosterone. But I never checked this testosterone until 3 years back. So, father fatigueness, muscle capacity, drive, muscle mass, sarcoidomal mass. I checked this testosterone. Testosterone was 1.2 nanogram per ml. So that means that severe male hypogonadism, MRI, everything was normal. So PSA was always 1.2 and 1.5 always. I've just put him on an android testosterone 40 milligram 2 times daily for the past so many years. And now almost we know cognitive function has improved, muscle power, even anemia. You know that testosterone is required for erythropoietin production. Anemia is improved. So in a female, you can give MHT till 60 years. Men, you can give safety 65 years. Oral testosterone undeclared can be safely given 75, 80. Keep on checking the PSA every 6 monthly, 3 monthly. It is going to be totally safe. In men with documented organic hypogonadism, it will be a hypopituitarism, craniopharyngioma, Coleman syndrome, or a Klinefelter syndrome, 47 XXY. Give an injection of a Serenose depot, TM depot. Otherwise, always go for a testosterone capsule, 40 milligram 3 times daily. Single capsule goes to 10 rupees only. Always take that. Ask the patient to take for 3 months, come with a repeat testosterone, PSA, PCV, and then decide to go forward or not. And testosterone gel is available. 1% testosterone gel, 5 to 10 gram. The trade secret in the cake in the doctors, friendly cake, no colleagues, just some area. Alkar number 1, Narama number 2, mustache, but the talk could come record in the medical report and at the Kirinal talk and put the report down it a doctor talk the young line at entry, other recording the colloquial language, but other one recorded other webinar, no one testosterone, erection, breast augmentation, loose talk, but suppose a guy or a film star comes and tell you, doctor, my libido is good, my penile length is good, my testicle volume is good, but I am not having facial body. Doctor, me she want to work in the living body, the Premature you take his testosterone 8 nanogram per ml. So testosterone is still facial body hair is not there. That shows that testosterone doesn't have sensitivity in his hair follicle. So giving a testosterone injection always will cause a polycythemia, osteotic sleep apnea, low HDL only. So him always dihydrotestosterone, because the testosterone which causes facial body hair is always DHT. Dihydrotestosterone cream may be useful. So DHT cream now is available. We can import it. So it is available from outside. It is known as Andractim. So facial body hair Andractim, 2.5%, 80 gram the tube. That is important online. And with that, you can put a mint top drops. Cushion will be in the mint top, 2, 5, 10% with a mint top, 10% applied on the face with an Andractim, which can increase the facial body hair locally in up to 80% of the people. So basically with this, I am going to the last thing. So this is the basic of ED. I remember the ED. Whenever I give, I always give every country as a paid talk only. But basically understand ED occurs psychogenic organic. Everything I've told you. 45 years and above, it is organic. Most common cause of ED is metabolic syndrome, sugar, BP, cholesterol, smoking. Treatment of ED is much more difficult. Prevention of ED is much more easier by taking a metformin, by taking a statin, by taking a sartan, and always continuing exercise. And the narrowest blood vessel in the body is a cavernous artery, which is getting clogged by your sugar, BP, cholesterol. The more wider is your coronary, carotid, and femoral, where you can put a catheter. Where a cavernous artery, you can't put a catheter. You can just augment that. So my age is 45, Deepu may be 35, another person may be 55 or 60. But in any age, we can prevent ED or prevent the worsening of erectile function by always protecting the endothelium. Men have to check the testosterone level. Testosterone level less than 3.5, considered as a late onset hypogonadism. But above the age of 45 for sex, always give an android testosterone, Serenose testosterone 40 milligram 3 times daily. Do a PSA, PCV before and 3 monthly. Rise in PSA more than 1.5 nanogram. Rise in PCV above 54% at diphthal. Otherwise, always continue safely 65 years, because capsule is not going to have a peak and valley. Many times capsule is always safest, but in organic hypogonadism, always give an injection per se. Go to the next slide. Next slide, Sandeep. Yeah, this is the treatment for ED. This is the last slide. Maybe I'll put one more slide if my brain allows. So what is the treatment of ED? The clinical scenario I'm telling, 50-year-old guy, just like a person which I see here in Sharjah, 2 days back, a big business person who is coming and telling me, Dr. Bobby, I have diabetes for past 20 years. So he is having 52 years. I have remarried again. Now my wife is 35 years, doctor. I want to have a good intercourse. I don't want a baby. I have remarried. My children are all settled abroad, but I want to have a good sexual life without having a drug. Is it possible or not? So I am checking his profile. I checked his testosterone. Testosterone is normal. Thyroid function, thyroid is normal. He's already undergone an angioplasty. He's on crest of 20 milligram rosuvastatin. That is less than 50 he has kept. So testo is normal, thyroid is normal. He's already on statin with an LDL cholesterol up to 55 or 52 is keeping. Liver function is normal. HbA1c is not. Metformin 1 gram BD with an additional Jardiance and Synjardy he's taking. So invariably his HbA1c is 6.2. PSA is 1.2. What can I do? I can't do anything because from my point, it is finished. He's already having normal testosterone. His thyroid is normal. He's already undergone angioplasty. So high intensity statin of Crestor, rosuvastatin 20, keeping his LDL 55. He's already on losartan with a beta blocker. He's already on metformin with a Jardiance, keeping his HbA1c normal. Prostate is normal. That means that he is having pure endothelial dysfunction. He's diabetic for 22 years, angioplasty at the age of 40 years. And still his penis is not working. That means that already his penile endothelium has been destroyed. I started him, sir, can you take a Cialis, that is Tadalafil, it is available in this country or any country, Tassel, 5, 10, 20. He's telling Dr. Bobby, already in Tadalafil, doctor, I can 3 or so bad, I performance. Can you 1 year back in 20 at the doctor, 6 months on the erection of Tingatin. That means that endothelium has been totally destroyed in spite of taking Tadalafil. Because what does Tadalafil do? Sildenafil, Tadalafil, Vadinafil, that is Viagra. Viagra doesn't regenerate endothelium. Endothelium produces nitric oxide. Nitric oxide converts GTP to cyclic GMP to 5-GMP. The breakdown of cyclic GMP is prevented by phosphodiesterase 5 inhibitor. But once you are a diabetic for 22 years and angioplasty, your endothelium is totally destroyed so that initially your PD5, Tadalafil was having an effect. After 5-10 years, your endothelium is destroyed so that you are taking a Tadalafil, but your nitric oxide production from endothelium is not at all there. So he has to go for a second and third line therapy. So this is the basic dictum. Whatever I've told you is the pakka basic of how to deal an erectile dysfunction. Let it be any highest American person who is coming or here, a common man. This is the basic dictum. Once you have an ED, always attack the primary cause. Testosterone low, treat that. Hypothyroidism, treat that. Dyslipidemia, treat that. Fat liver, treat that with an antioxidant, preferably vitamin E. HbA1c more than 6.5, treat that. Prostatitis, treat that. Everything is normal. Then you have to go for a first line therapy, that is PD5 inhibitor, sildenafil, Viagra, Tadalafil, Vadinafil. So what are the absolute contraindications of a Viagra? Suppose you want to give any of your patient a Tadalafil, Tassel 10 milligram or a Cialis 10 milligram. What are the absolute contraindications? Symptomatic heart disease, sorbitrate therapy, complex antihypertensive regime. So symptomatic heart disease, you don't give. Sorbitrate therapy, ask the patient to withhold sorbitrate 48 hours prior to that. That is why now the basic dictum, age more than 45 years, anyone coming for ED, always ask the patient to undergo a TMT. Because of rule of 65, 65% of the patient may be having underlying heart disease. Vice versa, when you start a PD5 inhibitor, some people may having a hypertensive or angina episode. So always it is safe for ask the patient for a TMT. Suppose a guy comes, you are asking for a TMT. TMT is normal, and you are going to start on a Tadalafil. So you are asking to take a Tadabilis or a Tassel 20 milligram. Sometimes a patient comes, doctor, Viagra is waste. Either matter urologist consultation, vitamin and ginkgo biloba, apomorphine, yohimbin, and a good guna. So always now the basic dictum is how to take at sildenafil, Tadalafil. It is known as a 6-hit hypothesis. What's the difference between sildenafil and Tadalafil? Sildenafil or Viagra, the flight of activity is for 4 hours. Tadalafil, the flight of activity is always for 36 hours. So what do you mean by flight of activity? The PD5 inhibitory capacity or nitric oxide augmentary capacity for sildenafil is for 4 hours. Tadalafil is for 36 hours. So you are starting Tadalafil for a person. You ask him to repeat once in 2 days or 48 hours only. Sildenafil you can repeat once in 24 hours per se. And what's the basic dictum? Always understand. Suppose you are taking a Tadalafil today evening at 8 o'clock. You know the PD5 inhibitory capacity is for 36 hours. So you can have an intercourse with your partner today evening at 8 o'clock, tomorrow evening at 8 o'clock, day after tomorrow at 8 o'clock. For 36 hours it works. Whereas you are taking a Viagra or sildenafil at 8 o'clock today, it acts for 4 hours. You can have an intercourse till 12 o'clock midnight. Tomorrow you want to have an intercourse, you have to again take one more Viagra. So basic dictum is the first line therapy in any person who don't respond to symptomatic treatment is a sildenafil, Tadalafil. Sildenafil, Viagra 25, 50, 75, 100. Tadalafil 5, 10, 20. But Tadalafil is always preferred. In US, it is known as a weekend pill. You take it Friday, it works till Monday morning for 48 hours. But never ask the patient to take a single tablet. Always ask the patient by Harrison and all the dictum to buy 6 tablets. It is not a 6-hit hypothesis. Ask the patient to take a tablet Monday, Wednesday, Friday, Monday, Wednesday, Friday, alternatively for 6 days. Because first day you may be taking a tadalafil, but your expectation may not be that much. You may be having a slight amount of sympathetic activity. So your PDE5 inhibitory action may not be working. So if you take it on a Wednesday again, Monday or Wednesday, you know that your sympathetic activity has come down. Slowly, your penile blood flow is increasing. You take it on a Friday, you know you have a cumulative effect of PDE5 inhibitor, your erection may be almost very good. Suppose a person is telling that, doctor, I have taken Monday, Wednesday, Friday for 6 days, but still my penile erection has not at all improved. Then you know that the corporal cavernous endothelium is totally finished. He is not a responder to a PDE5 inhibitor. So this is the dictum to go forward. I've told you the last slide I'm going. So first, you are supplementing testosterone, thyroid, cholesterol, fat liver, HbA1, PSA. Nothing is working. You are putting a patient on a tadalafil 20, Monday, Wednesday, Friday, ask her in TMT. The patient is saying, yes, doctor, I'm having 50% improvement. Let him continue. Like the guy which I saw, businessman 2 days back, he's taking tadalafil for 2 years. It was working. Now it is not working. For 6 months, you have to go for a second line therapy. What will you do for a patient where Viagra for 10 years or 2 years was working and now it is no longer working? You know, his endothelium is destroyed. You have to go for a second line therapy that is intracavernosal alprostadil. Alprostadil is a vasodilated prostaglandin, is PGE1. Now, Pfizer's, just like glucagon, heparin, pre-filled syringe is there. Your pre-filled syringe of Coverjet available in all the medical shops. Even in Kerala, that is known as Coverjet. It is alprostadil, 5, 10, 20 microgram. So just like a heparin syringe, pre-filled syringe is there. The powder is there. You can put it and dilute and take, just like glucagon, dilute and take it. You can catch your corpora cavernosal penis and self-inject and have an erection of your penis. And now we have powders also. Samarth Pharma, which produces hydrocortisone, Hyson tablet, and Floricor tablet. They have produced powders. So alprostadil powders you can buy, and other vasoactive prostaglandin, that is phentolamine, papaverine, everything you can buy as a powder. You can mix it and mix in the insulin syringe. You can inject yourself. So that is known as dimix, trimix, and tetramix. All the mixtures can be taken. But that is not a practical method. In a person who is 52 years is going to marry a lady of 32 years who want a frequent intercourse with his sexual partner, it is not a practical method to take a Coverjet alprostadil syringe, have an injection to the corpora cavernosa, have a pain, priapism, hematoma, have an intercourse every day or every other day. That's not a practical option. It is good in a person who wants an intercourse once in 2 months or once in 3 months. In a person where first line therapy fails, that is sildenafil, tadalafil, vadinafil, or the testosterone, all the symptomatic for first line phase, who want a constant, frequent intercourse with the sexual partner, second line therapy is not at all effective because discontinuation rate because of self-injection, according to having pain, hematoma, fibrosis, priapism, by injecting into your own corpora cavernosa, discontinuation rate is 50% at 1 year. So in a person who wants a frequent intercourse with the partner, the best option once the first line therapy fails is the third line therapy, that is penile prosthesis. Penile prosthesis is the mecca. Just whatever you say, it is the boon for people who love sex, who is having ED, organic ED, not responding to any oral therapy or symptomatic therapy. So penile prosthesis, satisfaction rate and continuation rate is 94% even at the end of 10 years. So first line therapy fails, go to the third line therapy, go to the next slide. Go to the second last slide. Sandeep, അടുത്തേക്ക് പോയേ. അടുത്തത്. Next. Yeah, this is the penile process. Go to the next slide. ഒന്നുകൂടെ തിരിച്ചു വരണം. No, next എന്ന് പറഞ്ഞാൽ അടുത്തത്. Previous അല്ല, അടുത്തത്. Yeah, so this is the mantra. Now go to the previous slide, Sandeep. Look at this and go. Yeah, this is the penile processes. ഞാൻ മലയാളത്തിൽ പറഞ്ഞാൽ എനിക്ക് ആരുടെയും ഫേസ് കാണുന്നില്ല. എത്ര ഡോക്ടേഴ്സ്, രണ്ടോ ഒന്നോ, പ്രോബ്ലി ദീപോ, ശിവകുമാർ സാർ കാണും, അല്ല രാധാകൃഷ്ണൻ സാർ. Basically understand. That's why I give my energy rarely. So basically understand, this is the penile process. A guy at the age of 83 years. This is the oldest age which I have sent for a penile process in India. An 83-year-old guy coming and asking me, Dr. Bobby, I have money like anything. I have my great-grandchildren per se. But only enjoyment that I get is having an intercourse. I fly at the age of 83 years also. Before Corona, I used to fly from one continent to another. Not one continent, one country to another. So much business thing. Business class only. He used to tell that I enjoy sex, but I can take a sildenafil, tadalafil because of two things. I've already undergone angioplasty and then I undergone bypass per se. I'm on sorbitrate, whatever it is. But in spite of doctors not recommend me, I take Cialis. That's the American brand of tadalafil that is available. He directly takes Cialis, but nothing is working. Cialis is not working for the past 7 years. So 83-year guy coming and telling me bypass undergone at 50 years for the past 7 years, right? From 75 to 83, his tadalafil is not at all working, but still he wants sex at the age of 83 years. How to go forward? He has no other option. First line therapy fails. Second line therapy with his trembling hand, he can't go for an intracavernous process. The only therapy is a penile process, and that's the best therapy in anyone with organic ED. And look at the anatomy. Penile processes, it is two types. It's an inflatable processes, non-inflatable processes. So inflatable is the most commonly used. Non-inflatable, nothing. You are having a semi-rigid process, just like your silicone implant of your breast. You are opening your corpora spongosa, just introducing the semi-rigid process inside the corpora spongosa and suturing it. So that semi-rigid process will have a erectile length of almost 2/3 of your erect penis, so that it will not be 100% erect. But whenever you want intercourse, you can have a semi-rigid process that is introduced, but that is least costly. So that is known as a non-inflatable penile process. But most commonly used throughout the world is this thing. It is an inflatable penile, but there is 2-piece and 3-piece. Look at the anatomy. This is a 2-piece one. 2-piece one means you are opening the both corpora cavernosa and introducing one cylinder into each corpora cavernosa. 3-piece, you are one thing. You are opening the corpora spongosa, both cavernosa, introducing 3 cylinders. Our normal blood flow is 3 artificial plastic cylinders or rubber cylinders. Look, you have a reservoir down. So you have a plastic reservoir you have down. So that contains nothing but water. That is fitted inside the scrotal cavity. Go to the next slide. Sandeep, next slide. So this is it. So you have a cylinder that is inside the corpora cavernosa. So this is one dimension. Look at the testis. You have a reservoir with fluid inside the testis. So how does erection occurs? You have a switch on button. Once you press the switch on button in the reservoir that is containing fluid, the fluid comes from the reservoir to the penile cylinder and the cylinder fully inflates. Once you put the switch off button, the fluid goes back from the cylinder back to the reservoir and your penis becomes flaccid. And this is the mantra for sex. 94% having a satisfactory rate, 94% continue even at the end of 10 years. This guy came to me, I sent him to Bleach Candy, invariably Rubin Shah for a penile process Bombay, because he's got to be the father of Indian andrology. So andrology in India, just like Srijitra Val by Unnithan. So you ask any urologist who's the father of Indian andrology, is Rubin Shah. So he's invariably, andrology is his concept. So he only devised the Shah metallic process, the non-inflatable process which can be used by Indians. Every Indian cannot afford a 6 lakh pump like this. Indian may afford a 1 lakh pump, still he wants for sex. So he has devised the Shah metallic non-inflatable process, semi-inflatable, but this is a foreign process. So invariably I send to him. So he came to me almost 6 months back. After 1.5 years, I was seeing him UA here. I asked him, he's 83, 84, 85 now. I asked him, how about the sex? He's telling, Dr. Bobby, why didn't you tell me before? I enjoy sex like anything. He's telling that whenever he goes for intercourse, he knows his penis is flaccid. So he knows that penile process inflatable is there and reservoir is there. He wants to have sex with, he will on the button. So invariably the fluid from the reservoir will fill the penis cylinder and the penis go into erection. No matter how much amount of intercourse the lady has, his penis will never go down. The ladies think that at the age of 84 years, how is this man having an intercourse per se? But he knows that it is the fluid that is filling the penis. So once the ladies move off, he puts off the switch off button and the fluid comes back to the reservoir and his penis goes to detuminescence. So that is it. Once there is a will, where there is a will, there is a way. Just like you give talk, you can give with your energy. Today was my OP day, Friday full OPD. You can give with my energy. You can give without energy. Once you want sex, you want to go for it, you have to go for it. But rather than going for all this complicated thing, rather than going for the second line therapy, intracavernous prostate, going for the third line therapy, going for a 6 lakh pump, a penile process, best is always prevention of ED. That is possible by preventing an endothelial dysfunction. That is why ED is in the hand of GPs, ED is in the hand of physician, ED is in the hand of endo and cardiologists, no longer in the hand of urologists. What urologists can do, they can put a processes, they can ask the patient to take a Caberjet injection, trimix, dimix, phentolamine, papaverine, they can't do anything. You and me can only prevent an ED by giving metformin, giving a statin, giving a sartan, prevent smoking and preventing having a BMI and giving a BMI less than 23. And the last thing of sex, go to the next slide. Next slide, Sandeep. And what about premature ejaculation? This is also important. Most disastrous form of sex and sexual dysfunction a guy can always suffer is a PME. Because erectile dysfunction occurs after 50 years, but PME can occur from the first night. Some guys come and say, doctor, I have an erection. No use, doctor. Before my wife has something, I have a kick of an orgasm, I have an ejaculation. Some people say, doctor, I just removed my pant or move my penis out of my pant. Immediately I have an ejaculation. So PME. What's the definition of PME by ACE guidelines? Having an ejaculation within 2 minutes of entry into the female vagina, that is premature ejaculation. So how do you treat PME? PME, I'm not going to deep. It is primary PME, secondary PME. Primary, it is due to increased sympathetic activity or increased sensory nerve supply of your penis. Secondary PME can be due to testosterone, prolactin, prostate, and a Peyronie's disease, fibrosing plaque-like disease of the penis, tunica albuginea, more common in diabetic patients. It can be due to performance anxiety. How do you treat a guy with a premature ejaculation? Suppose a guy is coming and telling, doctor, I have an intercourse, my ejaculation occurs in 2 minutes. I masturbate, I have an ejaculation after 20 minutes. That means that he's having a pure psychogenic premature ejaculation. Performance anxiety, learned behavior, exposure to a partner. Because if he is having an increased sensitivity to the peripheral nerves, he will have a premature ejaculation even on masturbation and intercourse. This on masturbation is getting 20 minutes. When he goes to his partner, he is losing in 2 minutes. So that is why PME, the drug of choice is nothing but SSRI, fluoxetine, paroxetine, sertraline, citalopam, fluoxetine or Prozac, the Pfizer's Prozac, the mantra drug before Viagra. That was a drug of choice, but fluoxetine acts very slowly after 3 weeks. Now, ultra long-acting SSRI, that is depoxetine, has come. So depoxetine in Duralast, 30 to 60 milligram, you can give 1 hour before having intercourse. That can control the premature ejaculation due to performance anxiety, learned behavior, exposure to a new sexual partner. Previously, many people used to, I'm coming from Gulf, I have spray for control premature ejaculation. That is nothing. That is 1% lignocaine jelly that is given for dental anesthesia. Now, the drug of choice of PME, unless the patient has a secondary PME of testosterone, prolactin, prostate, or Peyronie, is always nothing but SSRI, ultra short-acting SSRI of depoxetine or Duralast always work. Now you have a tadalafil combination with depoxetine also that is available. Now finish it off. Go to the second slide. Next slide. Yeah, next slide. Finish. So just go before slide. Yeah, this is the last slide. I don't know how many ladies are there, how many men are there, I don't know. But whatever I've told you, that is one guy hearing, that is abuse. This is it. So what about female sexual dysfunction? Female sexual dysfunction, only understand females also have decreased libido, that is frigidity, decreased vaginal lubrication, dyspareunia, vaginismus, anorgasmia, or recurrent vulvovaginal candidiasis. What is female Viagra? I just told for this only. What is going to happen if you are giving a sildenafil 100 milligram or a tadalafil or Cialis 20 milligram to your wife or your partner? Nothing is going to occur because tadalafil is a vasodilator. It will increase the blood flow to the labia majora, minora, clitoris, your vulva, vagina, everywhere, but it did not cause an orgasm because PDE5 inhibitor is a local vasodilator. It doesn't cross the blood-brain barrier. So the female Viagra is 5-HT1A agonist, that is flibanserin, ADDYA. That is now US FDA approved for use. It acts on the amygdala and limbic system and cause an orgasm. Because orgasm is a function that occurs from the amygdala and limbic system nucleus. It's a vasodilatation of the penis that occurs due to PDE5 inhibitor. You kick, you get in the brain, but invariably your penis has to work for the kick to get in the amygdala limbic system. So female Viagra is not tadalafil, it is not sildenafil, it is not vadinafil per se. It is nothing but flibanserin or ADI, that is 5-HT1A agonist, 100 milligram once daily for 8 weeks. Even in Kerala, some people use it because online also it's available. One tablet costs you around 800 rupees. It is given in the morning because some people it can cause sedation, but many times people don't have it. Female libido is more controlled by mind than any of the thing because females have a mental attachment to a male per se. They get an orgasm, they get a mood, everything, provided vaginal lubrication to be given. All these drugs may not be useful in females because men have an organ that is actively working. Female is always a passive sexual partner. Go to the next slide. Next slide. Yeah, this is it. So basically understand whatever people are there, I don't know, but Deepu, Radhakrishnan sir, Geeta Philip madam, everyone, thank you from whatever this thing. Basic about erectile dysfunction, how to approach ED. Because whatever you speak, theory is there, but doing from heart, from what you know by practicality. What is your passion? Just practice that, just like that. This is sex, and prevention of sex is most important. And spending time, not writing a Viagra and sending any 24 sildenafil Viagra. Don't discard the patient. Patient, that may be the biggest problem in life. Wife commenting that his libido is not good. Wife commenting that your ejaculatory time is so poor. Wife commenting that your penile size is so poor. You may be Napoleon. You may be the biggest conqueror, but you are bad compared with your partner, you have a mental agony at any age per se. That's why many people claim that Napoleon Bonaparte. We have heard about Napoleon the Great who died in St. Helena. Napoleon told us, able was right till I see the Elba. You write it everywhere. You know, Napoleon was the biggest conqueror, but no one knows whether Napoleon has an actual higher per se. Because many of the studies say that when autopsy of Napoleon was done, it showed a gynecomastia with an atrophic testis. So many people believe that it could be Napoleon, maybe a Klinefelter mosaic. But some people believe that it's the arsenic poisoning which Napoleon has been subjected to, which produced a gynecomastia and testicular atrophy. We know Napoleon had so many lovers, but he never had a successful sexual partner. Whenever he goes for invasion, his partner goes with another of his general in France per se. So invariably, you may be a conqueror throughout the world, but if you are not able to conquer your partner, invariably your mental agony is there. But now there are so many options for ED. So first line, second line, third line, you name it, you have it. Thank you.
Thank you, Dr. Bobby. Can we just see if there are any questions on the chat box? Anybody wants any clarifications from Dr. Bobby?
Dr. Bobby's talk is very fascinating, particularly linking ED to CAD through a metabolic syndrome and stressing that it's endothelial health, which actually is so important. And he describes so nicely an algorithmic approach to managing ED. So, Christopher, very nice presentation.
Thank you, sir.
Bobby, just one clarification. What are the medications that people should be wary of when they go through the pharmaceutical list of patients, especially with ED? I remember you touching upon beta blockers and saying that it's not a big role, but are there any other drugs that we should be a little bit more careful about?
Yeah. Deepu, every drug which causes high prolactin, every drug which causes a parasympathetic activity, anticholinergic, is always killing the sex. Because sympathetic is inhibitory for sex, parasympathetic is activatory. Sympathetic is adrenaline, parasympathetic acetylcholine. That is why antipsychotic, antidepressant. Because invariably hyperprolactinemia and the anticholinergic action, antacid, omeprazole, pantoprazole, and all the diuretics causing. So whenever you give an androgen, flutamide, spironolactone, ciprofloxacin, rosuvastatin, Dianogen, finasteride, all the alpha blockers, everything kills sex. But these can only be contributed to sexual dysfunction. That is why the primary culprit is your endothelial dysfunction, obesity, and this can just be contributory unless you have a retrograde ejaculation. Retrograde ejaculation is produced by tricyclic antidepressant. Retrograde ejaculation is produced. You can hear me?
Yes, yes.
Yes, Bobby, we can hear
you. Yeah. Retrograde ejaculation is caused by tricyclic antidepressant. Retrograde ejaculation is caused by focus. Otherwise, always mind tricyclic antidepressant, antipsychotic, antacid, especially containing domperidone, levosulfide. The biggest culprit which caused high prolactin was previously metoclopramide, domperidone. Now it's levosulfide. If your domstalel, the Rabonic plus, that also causes ED, and the alpha-1 blockers and tricyclic antidepressant per se. Otherwise, beta blockers are just contributory. It is hypertension included in metabolic syndrome that kills the sex. Kekao,
Bobby, chat box questions on I think we don't have questions.
Penile process is always remember. Because whenever a patient who is having non-responsive to any product, because they tell I'm depressed, doctor, I tried everything, now I don't want. Send them to a good urologist who has hands-on experience in a penile process. That name is very, just like your surgeon was telling, a good surgeon taking out the thyroid without injuring the parathyroid, without injuring the recurrent nerve. That is very, very important because once you have a penile process introduction, you 100% lose your natural erection because your endothelium is totally torn and your process is getting fit. 1% of people can have a malfunction of a machine. Once your malfunction of machine once occurs, second fitting of a process may not be successful. That is why first sending to a good center where a good process step is always important for a good penile process is working.
Dr. Bobby. Yes, Dr. Bobby, Dr. Prasanna here. I'd like to know any contraindications patient with hepatic dysfunction or kidney dysfunction patient to give this ternafil or sildenafil. Any contraindications? Patient with
what are the conditions?
Hello.
Sorry, Kekao. I am
Ipo kekam. Sorry, sir.
What are the conditions where you require a lower dose of sildenafil, tadalafil? So sildenafil in a dose of 25 to 50 milligram, tadalafil 5 to 10 milligram in 4 conditions: age more than 65 years, patient with liver disease, renal disease, and cytochrome P450 inhibitors, which are enzyme inhibitors, cimetidine, erythromycin, ciprofloxacin. So whenever you give for a patient with liver disease, whenever you give for a patient with renal disease, cytochrome P450 inhibitors, age more than 65 years, give tadalafil in a dose of 10 milligram. Now the guidelines say that tadalafil 5 and 10 milligram can be given even in a patient with coronary artery disease who is not on nitrate therapy. And tadalafil is indicated with CD, number 2, benign prostatic hypertrophy. 40 milligram for tadalafil has given for primary pulmonary. So up to 10 can you safely 40 milligram in primary pulmonary.
You are probably not audible. You are not audible, Dr. Bobby. Not audible well.
Okay, ipo kekao.
Ipo keka. Yeah.
Sare, on the adittu vechu parayuva. Appo sare manasilakkana tadalafil up to 5 to 10 milligram can be given in any condition, including patient with liver disease, renal disease, age more than 65. 5 to 10 milligram can be given as a primary therapy in benign prostatic hypertrophy. 40 milligram can be given even in patients with primary pulmonary hypertension. So kannu orange 5-10 milligram except in any patient on nitrate. Any age you can give.
Dr. Bobby, one thing about testosterone therapy, I think most of us should not forget that CA prostate is the commonest malignancy in the males.
Yeah.
So we should
but CA prostate is never induced by testosterone. Testosterone replacement therapy in hypogonadal men never induces prostatic cancer. It uncovers the microscopic focal prostatic carcinoma. So before starting testosterone replacement therapy, do PSA. Repeat PSA every 3 to 6 monthly. If the rise in PSA is more than 1.5 nanogram, it shows that your testosterone is causing uncovering. Send to your urologist, go for a biopsy. Now studies say that even in patients with CA prostate with bilateral medical orchidectomy, lower dose of testosterone increases the mood, libido, quality of life, osteoporosis, and cognitive function.
Yeah. In fact, I could hear. One more question, because quite often we physicians fail to do the assay for FSH, LH, and even prolactin or testosterone. So you recommend that any patient who's coming with impotence, and if we suspect organic ED, then we should go for this.
Always. That's a basic dictum. Male means it is testosterone. Always. Testosterone, thyroid should be done. Testosterone less than 3.5, then only go for FSLS and prolactin. You should ask me the question when to do free testosterone. I thought you are going to ask that question. Total testosterone is the basic dictum, because free testosterone assays are not specific. So now the guidelines say that you should do a total testosterone with an SHBG, sex hormone binding globulin. In conditions where SHBG high or low, you can ask for a free testosterone. But practically, it is always you ask total plus free testosterone, even though because patient have to come 3 times to you. Testosterone, SHBG, then free testosterone. Patient will be thinking what this guy is doing. So I write everything one shot only. FSLS, total testosterone, prolactin. I write in one shot.
Okay, thank you. The same as the PSA. Yeah.
Deepu, clear?
Bobby. The concepts are very well explained, and I think it was a very practical way of coaching that was more important rather than a lot of theory. And I think you explained it with a lot of passion, and it was very clear that the concepts have to be taken with practical approaches, which we were looking forward to. And I'm sure the audience would have been extremely glad that you clarified all the points very well.
Thank you, sir. Thank you.
Can we wind up the talk for the day?
Yeah, sure. Thank you, Dr. Deepu, for conducting it so well. In fact, your introduction was also quite beautiful. When we were waiting till Dr. Bobby took over, there was an intermission. Thank you, Dr. Deepu, for sharing the session so well. And Dr. Bobby's talk, as usual, was very illuminating. And he makes the concept so crystal clear to whoever listens to him. That's an extraordinary speech. Thank you, Dr. Bobby.
Thank you, sir. Thank you, Deepu, everyone. Tadashna, sir. Prasanna, sir, madam, everyone. Thank you. Sandeep also, the USP team there. Because I was here. I also wanted to give the talk for Christian Club, but I could not come back from here. Golden miss 20 20 days here, NRI status it will be gone. So I'm 20 days here, 10 days there for 2 years. Thank you, sir. Thank you.
Anyway, we could never had a physical meeting as such also because of the current pandemic situation. Thank you. So let's go to the next part of today's meet. May I invite the Secretary, Dr. Sridhar, for word of thanks and to discuss the organization matters, association matters.
Thank you, sir. Thank you, sir. Good evening and good evening, ladies and gentlemen. Thank you all for attending today's meeting. We have had 2 extremely enlightening sessions today. Let me thank the team from Aster Medicity for having presented their challenging clinical cases on papillary cancer of thyroid in pregnancy in the most unique way. And the following panel discussion was also very good to watch. Thank you, Dr. Mayuri Rajapurkar, Dr. Tina Ann Joy, Dr. Shamina, Dr. Jyoti Lakshmi, Dr. Shagos, and Dr. Vipin. I thank Dr. Geeta Phillips, madam, for moderating the session and also having suggested to bring their team here in the first place. Next, I would like to thank today's guest speaker, Dr. Bobby K. Mathew, who is an eminent orator, and he has joined us all the way from Sharjah to give us a brilliant overview on the topic of erectile dysfunction, and I'm sure it will help all the physicians in their day-to-day practice. I also thank Dr. Deepu George for having chaired this session and expressed his expert views. Let me extend my thanks to the audiovisual team led by Mr. Rinesh, and thanks to USV Pharmaceuticals for having generously sponsored this session. Last but not the least, let me thank each one of you for having attended today's session, and thank you for your valuable presence, and it inspires us to work harder. With this, we come to the end of today's meeting, and over to the chairman, API Cochin, for closing remarks.
Thank you everyone for taking part in today's meet, particularly the audience, without whom this meet is absolutely useless. So some of us have also contributed to its discussion, and today's session on the whole has been extremely educative. And a lot of practical tips in our day-to-day practice, as the secretary brought out. Well, as far as the organization matter is concerned, there's nothing more to discuss. No, Sheila, do you have anything to say?
Not yet, sir.
Yeah, okay, fine. So let us conclude. We'll conclude today's session as such. Thank you, everybody. Thank you.
Okay. Good night, sir.
Good night. Good night. Bye-bye.